Again, I'd like to thank us and the committee for giving me this opportunity to be a part of this very famous endoscopy symposium. My talk is on obesity and insulin resistance syndrome, what we can achieve with endoscopic therapy. Of course, obesity is now epidemic all over the world, and there's severe toll of comorbid illnesses with this. The current surgical strategies will not work, and even the current conservative strategies. And this was a study published from Johns Hopkins, which compared endoscopic sleeve gastroplasty versus high intensity diet and lifestyle therapy. And you can see very clearly that in spite of high intensity diet and lifestyle therapies, and these people were actually were in a continuous program, still control of obesity was not very adequate. Although we know that metabolic surgery is effective, and there are now several studies to suggest this, uh, unfortunately, metabolic surgery is something that most patients do not accept. Uh, so, therefore, its penetration into patients with obesity is not as effective as it should be. What is the other alternative? There are other alternatives like, of course, drug therapies and so on, and these are not so effective. The problem with bariatric surgery is that not only there's some morbidity and mortality, but also we know that some of these patients can become very severely malnourished, and about 25% actually regain weight. So, therefore, endoscopic therapy has started to become an alternative in these patients. Uh, Endoscopy could be an ambulatory procedure. It's safe, avoids anesthesia, and of course, it's probably more cost effective than the current laparoscopic procedure. And even when the laparoscopic procedure fails, as I'll show you later, you could still do an endoscopic procedure. There are several endoscopic techniques in bariatric surgery. These are grossly restrictive and malabsorptive, and others that I'll come to a little later. But restrictive ones are putting in balloons or prostheses, whereas more permanent ones are endoluminal gastroplasty. Malabsorptive ones are the jejunal bypass sleeve and even esophageal bypass sleeve and magnetic bypass that can also be done. This gastric space occupying devices like balloons or even the full sense device that you have here are very popular in certain countries, but unfortunately they have a temporary effect. And this was the US pivotal study which clearly showed that there is about 4-5% weight loss with different balloons that are now available commercially. I won't go into the details of this, but you can see that you can get a significant weight loss in these cases. Not only do you get weight loss, but intragastric balloon also induces significant metabolic and histological improvement, uh, especially in non-alcoholic steatohepatitis. And this is a study which came from Barham's group in Mayo Rochester, and you can see that both steatosis, inflammation, and fibrotic score all decreased when these patients were on balloons. So this is, I think, important to remember. What about long-term weight loss with balloons? Unfortunately, most of these balloons are put only for 6 months, have to be removed. But there's some evidence that some of these balloons can be used for 1 year, and you can repeatedly change them. But this is not, of course, a practical solution. So in terms of long-term, it's not a very good solution to use these balloons. So the other procedures that are more long-term are the restrictive approaches that we have, which can be done endoscopically. And we have a variety of these. And all of this, I try and do gastric remodeling, plication of the body, because there's no evidence that there are baroreceptors in the stomach, which are directly transmitting impulses to the hypothalamus. And this is responsible for the satiety reflex. And therefore, if you can actually decrease the body of the stomach, make it narrower, the baroreceptors become more sensitive and they act more effectively. Also, another concept that has come in is that the fundus should not be actually removed in these patients, because this fundus gastric accommodation reflex also is very important. So if you have a fundus which is very large, then the food gets accumulated there, and then again stimuli go to the hypothalamus, indicating that there is satiety in these patients. So these are the two important concepts that one has to have in mind when endoscopic therapy is being applied. There are several techniques available again to do gastric suturing or remodeling. The standard one for many years has been the Apollo overstitch. POSE, or the primary obesity surgery endoluminal therapy, is also available. And of course, Endomina, which is also mostly used in Europe, again, very effective technique. The Apollo overstitch is a little complicated to use, but learning curve is about 30 cases, and you can see that it can be quite effective in reducing the lumen of the stomach. POSE is a little different technique, and now the POSE 2 procedure predominantly produces these type of staplers, mainly on the greater of the stomach, decreasing the size of the stomach. Among all these devices, in my view, the easiest to use is, of course, the Endomina, and you can see this is a device that can be attached to the tip of the endoscope, a device that has come from Jack Davies unit in Brussels. Very effectively decreases the size. And again, I don't want to go into the studies, but there are now studies showing very clearly that it can decrease significant weight loss. All these devices, both ESG, POSE, and so on, again, many studies have shown that they can achieve weight loss of up to about 8 to 9% in these patients. What about long-term effect of this? Unlike balloons, these sleeve gastroplasty techniques have a much longer efficacy, and you can see this from the study from Ream's unit that even after 5 years, the weight loss that was attained initially continued going, and then of course stabilized at 5 years. So this has an efficacy of at least for 5 years, we know now. There's also some evidence that if you can combine this sleeve gastroplasty with drugs like liraglutide, then you can actually increase the weight loss much more. And this is again a study from Barham's unit, which showed that when liraglutide was given about 5 months after the procedure, you can see that there's significant weight loss, much more than with just ESG. So the future may be a combination of ESG along with some of these drugs. Also, again, this interesting study from Ream's unit showed that not only does weight loss occur, as you can see here, but even earlier in the weight loss, insulin resistance comes down. We don't know the explanation for this, but in addition to this, hepatic fibrosis and of course inflammation also comes down. So not only is weight loss occurring, but unrelated to the weight loss, extent of weight loss, you're also seeing certain metabolic parameters changing in these patients. And these are very recent studies which suggest that in addition to the small intestine, the stomach also seems to play a role in this metabolic process and insulin resistance. What about comparison between endoscopic sleeve gastroplasty versus laparoscopic sleeve gastroplasty? And okay, we have these studies to suggest that both have equal efficacy, and of course you have much lower morbidity with ESG. The extent of weight loss with ESG is a little less compared to laparoscopic sleeve gastrectomy, but I think we have fairly equal results. And even if you look at what happens in terms of metabolic changes, you can see that both laparoscopic and endoscopic sleeve gastroplasties have a similar metabolic effect in terms of insulin resistance and so on. In patients who have had a laparoscopic sleeve gastroplasty, if they continue to put on weight later on because the stomach size increases, you can actually do an endoscopic sleeve gastroplasty to overcome this. So this is a revision endoscopic sleeve gastroplasty for patients who have had laparoscopic sleeve gastrectomy and failed at that. So I think, again, some important information coming in recently. There are other endoscopic techniques, again, I don't want to go into the details of this, which are used in certain parts of the world, but not uniformly, like the ASPA assist technique, where stomach contents are actually using a peg-like port. They're evacuated after a meal, or the magnetic devices, which are actually used to create an anastomosis between different parts of the small intestine to bypass and therefore producing a malabsorptive-like phenomena. Again, these are very early results, and I think we require more clinical use before we can advocate them. So weight loss by these, especially the restrictive techniques that we have, the suture technique is now well established, but the metabolic component isn't as much. And we now know that metabolic syndrome is becoming more and more common, especially combination of diabetes, obesity, and non-alcoholic fatty liver disease. We used to think that the metabolic control was in the pancreas, but increasingly we now realize that the metabolic control may actually be in the small intestine, and therefore as endoscopists we have the ability to control this metabolic phenomena in the small intestine. So I think there are a large number of studies now showing that the duodenum could be the center of metabolic control. A variety of hormones are released from the duodenum, which would result in decreasing glucose production, increasing insulin sensitivity, and so on. Again, I don't have the time to go into all of this, but the duodenum, especially the second, third, and fourth part of the duodenum, seem to have a very active role in the metabolic control. So it's hypothesized that in the duodenum, second, third, and fourth part of the duodenum, there are incretins and anti-incretins, which can be stimulated by the food, which ultimately control insulin sensitivity. And therefore, if you can change the duodenal mucosa, second, third, fourth part of the duodenum, you can actually change these metabolic controls that are occurring. This was evident to us even before, because the patients who underwent Roux-en-Y by gastric bypass lost weight after a couple of weeks or months, but the insulin sensitivity increased immediately, even after 3 to 4 days after the bypass surgery, suggesting there's other phenomena which was actually doing this. And these are elegant experiments that came from David Cummings and his group, who showed that in patients who were hyperglycemic, underwent Roux-en-Y bypass, when they were given normal feeds because of the bypass, the food did not go into the second part of the duodenum, and they continued to be normal glycemic. But when they put a gastrostomy tube and feed it these patients through the remnant stomach, you find that they became again hyperglycemic, lost control, indicating that duodenum control was responsible for this. And finally, when this was removed, they again became normoglycemic. So this very important work in humans showed that the duodenum seems to have an important role in the control of metabolic processes. So the duodenal nutrient passage influences insulin sensitivity. So how can we change this nutrient passage duodenum? And one of the methods is to actually have these tubes which can bypass the duodenum if they're attached in the stomach. And endobarrier was one such concept, which actually initially came in South America for decreasing weight, but subsequently studies showed that not only that it decreased weight, which was very modest, but had very good control of the insulin resistance. And you can see the studies that came suggested that patients with type 2 diabetes had a decreased A1C. But the problem with these bypass liners was that because of the barbs that were present at the tip of these liners to attach it to the duodenum, it could produce portal pyemia and hepatic abscesses, and therefore they have been withdrawn from clinical practice. We tried to modify this by using new type of endosleeve, and this is a sleeve that we modified along with Metamormics company in the United States. And you can see that using the sleeve, which actually uses a stent-like device to fix it to the pyloric region, we find that the duodenal contents, the stomach contents are bypassing the duodenum to go into the jejunum with adequate control of type 2 diabetes or insulin resistance. We're still working on this to see if these tubes can be placed for long term, but unfortunately, when these tubes are removed, you can see that the glycemic control again goes back to normal. So therefore, this is not a permanent method. So can we think of a more permanent method? This was again very elegant experiments that were done to look at abrading the mucosa of a GK rats which are spontaneously diabetic. And when these duodenal mucosa is abraded, these spontaneous diabetic rats become euglycemic. And they've been worked to show that these rats, when once the mucosa is completely abraded, would show improved glucose tolerance, indicating that the new mucosa is not producing the same metabolic problems. Again, studies were further extended, and this is a large multicentric group which has been doing this in the swine to show that if you can actually inject in the submucosa and then ablate the duodenal mucosa, the new mucosa which regenerates has a different type of endocrine hormonal cells, and they can result in a better metabolic control. So duodenal mucosal resurfacing procedure, which is now been done in some centers, especially in trial basis, which uses heat from hot water, that is thermal heat, to ablate these mucosal surfaces, is shown to be quite effective in certain situations. And this is a technique, the DMR technique, which is using the Revita balloon, which can completely ablate the duodenal mucosa. And you can see from these pictures that using DMR, that you can actually raise the mucosa and then burn the mucosa, and after a couple of months, the mucosa comes back to normal. There are very few adverse effects with this technique. 2 stenosis have been reported, which have been treated endoscopically. And of course, we have the newer balloons, a single balloon which can do both the injection and burn the mucosa. This is a hydrothermal technique, which is actually destroying the duodenal mucosa selectively without injuring the submucosa or the muscle layer. And of course, endoscopically it can be monitored so that you know the amount of injury that's occurring. And this new balloon makes it much easier and technically more safer to do this procedure. And you can see that the balloon is deflated and removed, and then endoscopy is done to see the extent of ablation. You can see over 70% of the surface is ablated using this technique. There's several studies on duodenal mucosal resurfacing, the Revita 1, 2, Inspire NASH, and even for polycystic ovarian syndrome, where the Domina study has been done. So these studies are starting to show that ablating the duodenal mucosa would result in better metabolic control, and metabolic syndrome to some extent can be controlled with this. The Revita 1 study was the first case control study, which showed very clearly that A1C changes of up to 1.2% occur, persisting up to 12 months. And of course, the fasting sugar also is better controlled when this is done in patients with type 2 diabetes. This was, again, the multicentric trial which published the study which showed that not only A1C, but also insulin resistance, and of course, the liver enzymes, ALT and AST, have also decreased when this was a procedure and followed up to 6 months. Can these procedures really decrease the need for insulin in our patients with type 2 diabetes? And this is a study which came from Netherlands, where they used a combination of mucosal resurfacing along with a GLP analog, IRA. And you can see after 6 months, 69% of the patients are off insulin with control of A1C below 7.5. And as they continued the follow-up, again, after 12 months, 56%, and after 18 months, over 50% of the patients still did not require the need for insulin. I think this is very exciting data suggesting that if you can resurface the duodenal mucosa, you can achieve insulin sensitivity in these patients. Not only insulin sensitivity, but a variety of metabolic problems can be controlled. And again, studies to show that you reduce glycemia, also improve hepatic indices, insulin sensitization occurs, also there's a decreased lactate pyruvate ratio, and finally other metabolic parameters, lipids for example, show improvement, and antioxidant capacity also increase. So there's a wide range of improvements occurring in a variety of metabolic processes with DMR, and DMR I think is going to be studied much more further in a randomized blinded technique, but better techniques of DMR are coming in, and these are techniques, this is Dr. Barham's research on trying to use electroporation in these patients so that it makes it much more simpler to do DMR. And finally, we know that the duodenum is the center for metabolic control in the body. And we also know that in addition to its physiological role, the duodenum the mucosa can become hypertrophic, hyperplastic, giving rise to an abnormal enteroendocrine population. And these signals can give rise to insulin resistance and so on. But we can bypass the duodenum either by resurfacing it or producing, having the sleeves so that the metabolic controls can occur. So the answer for metabolic syndrome or for insulin resistance seems to be a simple endoscope working in the duodenum second or third part. Now, coming back to who qualifies for weight loss surgery procedures, you know that patients who are overweight, would mostly be treated with diet and lifestyle changes. Those who are obese, endoscopy, the various techniques we discussed, and those who are severely or morbidly obese, is to have laparoscopy. But hopefully, with all these new endoscopic techniques coming in, showing better results, comparison with laparoscopy showing that equivalent efficacy, even those who are severely obese or morbidly obese will ultimately get treated with endoscopy. And finally, I think it's important to realize that treatment of these patients, obesity, metabolic syndrome, is a multidisciplinary approach with not only the gastrointestinal endoscopists coming in, but bariatric surgery, endocrinologists, dietitians, psychiatrists, everybody working together. And that's when we get the best results. Thank you for your attention.